symptoms or mucosal damage, that's what we call NERD, a non-erosive reflux disease, symptoms without damage. So if you go for the investigation, whenever for the NERD, the patient, you may find normal mucosa of esophagus as well as the stomach, but the patient must be having symptoms. So that's what we call NERD. And usually symptoms may be typical as well as can be atypical. So what are the typical symptoms usually? Most of the people has faced heartburn. That's what we call retrostomal burning sensation. Most commonly postprandial, nocturnal, by eating fatty food, spicy food, acidic food, and relief with antacids, buttermilk, and probably worsen with recumbency. Acid regurgitation, again, perceptions, basically what regurg means, the perception of gastric contents reflux in the mouth or hypopharynx, feeling an abnormal taste in mouth. That's what we call bitter, acidic, or water brush. What are the atypical symptoms of GERD? The atypical symptom, most common atypical symptom is some of the time it's nausea and chest pain. So at some point in time, it is difficult to differentiate between, is it the cardiac pain or is it non-cardiac pain, means GERD. So you may find a similar kind of pain with reflux esophagitis or advanced GERD as you may find in the patients with myocardial infarction. So you may have atypical symptoms like dysphagia, odynophagia, nausea, chest pain, dyspepsia, upper abdominal bloating, belching, heartburn. So extraesophageal, if the patient is having, some of the time the patient comes to you with a chronic cough, and one of the cause of chronic cough is the GERD. Worseness, laryngitis, you may find bronchospasm, and low sensation. So what we have learned so far, what is GERD? It's a reflux of gastric contents into the esophagus. And what are the typical symptoms? The heartburn, retrostomal burning, abdominal bloating. And what are the atypical symptoms? It might be chest pain, further divided into esophageal and extraesophageal. So the common atypical symptoms of GERD is nausea and the chest pain and the dyspepsia. And the other extraesophageal, the common extraesophageal is chronic cough. So you can see here the complications of GERD. There are different complications of GERD here, and one is peptic stricture, means you can say esophageal stricture, metaplastic disease like Barrett's esophagus, dysplastic disease, means adenocarcinoma, laryngitis, and pulmonary disease. So again, if you talk about this peptic structure, the topic of today's lecture is about the complications. Most of, but we'll be focusing on GERD. That is the most common, and everyone probably 1/3 of every person is facing this kind of symptoms. So you can see here what we were talking about. One of the complications is what we call erosive esophagitis. It's responsible for 40 to 60% of GERD symptoms. And severity of symptoms often fail to match, and what we call severity of erosive esophagitis. So you can see here, this is the normal mucosa, and you can see here the abnormal mucosa. So that's what we call the inflammation of the esophagus, reflux, and causing erosion, and causing erosive esophagitis. So you can see here, continuous reflux of gastric content can lead to, you can see the structure, and this will lead to the symptoms, the chest pain. So the result of, if the patient of reflux esophagitis is not properly treated, then this may lead to reflux esophagitis, and it may need dilatation through any kind of procedure, like endoscopic, through surgical, whichever way you want to go. And common in the distal esophagus and are generally 1 to 2 centimeter in length. And mostly, you see, we normally divide esophagus into 3 parts, upper, middle, and lower. So it's most common in the distal, lower part. So this is again Barrett's esophagus. As a third year medical student, I just wanted to let you know about your exam that when I went to take the exam in JSMU, that they had the slide of Barrett's esophagus, and they asked about the definition of Barrett's esophagus and what are the symptoms, and it is the complication of what. So probably it's a complication of reflux esophagitis or chronic GERD that is not properly treated. So they usually ask about the columnar metaplasia of the esophagus, that is what we call replacement of the squamous epithelial lining of the esophagus by specialized columnar type epithelium. So the replacement of squamous epithelial cells to the specialized columnar type of epithelium is one histopathological findings, and most of the patients with Barrett's esophagus develop this development of adenocarcinoma, and 30% of developing esophageal stricture. So what are the red flag symptoms when you are concerned? So the red flag symptoms you can see here, and whenever you consider the endoscopy. So if a patient is having dysphagia, means difficulty in swallowing, or dynophagia, means painful swallowing, persistent nausea, refractory nausea and vomiting, black colored stool, melena, anemia, weight loss, anorexia, and persistent duration of symptoms not resolved by anything, not responding to proton pump inhibitor, family history of peptic ulcer disease. You need to think about, and this is one of the common, is Caucasian male 50 years, of old, sex greater than 10 years, concerning for Barrett's esophagus. So how you are going to diagnose the Barrett's? Again, depending on the history, most of the patient used to give trials of people. We'll talk about it. Esophageal pH monitoring, definitely. If the acidic pH less than 7, definitely you will be considering for. Normally, diagnosis low. Normally, the diagnosis of GERD can be based on clinical symptoms alone, and the patient can start with empiric therapy. So, how you're going to diagnose the patient with GERD? So, esophagitis. So you can see here, this is you need to see, is it the reflux, or it's infectious, or it's a drug induced, or it's eosinophilic. So again, if you're talking about esophagitis and if patient is infectious, probably it could be fungal. Why? I've seen one patient with herpes esophagitis, and patient was having severe kind of pain. Eosinophilic allergy can lead to esophagitis as well. H. pylori testing prior to PPI. Mind it, if you are suspecting a patient with gastritis or esophagitis and you are suspecting the patient with H. pylori, patient should be off H. pylori, or patient should be off proton pump inhibitor for at least 72 hours prior for H. pylori testing. And there are different ways for H. pylori testing. The blood test is not reliable, serology is not reliable. The best test for H. pylori is the stool as well as the urea blood testing. Urea blood testing is the gold standard. It's quite expensive, but the stool for H. pylori is the reasonable one. But nowadays, at our facility, they are doing urea blood testing at quite a reasonable cost. So what sort of diagnostic considerations or how you are going to work or empirical treatment for H. pylori or the GERD? Although response to PPI is not a definitive diagnosis of GERD, again, in clinical practice, it is more appropriate to start empirical treatment than to pursue reflux pH monitoring. Symptoms that do not improve warrant further evaluation to demonstrate the existence of GERD and evaluate for an alternative diagnosis. See, you can see here, every patient with GERD, most of the patients with GERD usually we usually consider on the clinical basis. Every patient should not go for endoscopy. And who should be going for endoscopy? As I mentioned, red flag symptoms, persistent nausea, vomiting, diarrhea, dysphagia, weight loss, melena, bleeding from inside. So indicated for suspected GERD plus red flag or symptom resistant to twice daily PPI therapy. So twice daily PPI therapy, there are different kind of PPI therapies and every PPI has different dose. The other indication is esophagitis or Barrett's esophagus. It's for diagnostic. So as I was telling you, non-erosive reflux disease, 62% of patients with typical symptoms of GERD will have normal EGD. So 62% is a high number. So if you are going for patient endoscopy and if you find the normal endoscopy, it doesn't mean that the patient does not have esophagitis. So other diagnostic workup means include ambulatory pH monitoring, persistent symptoms despite medical therapy, confirmatory testing in patients with normal HD, esophageal manometry for dysmotility and no period solid, no period meal SD diagnostic. So anyone have any questions so far? So can we a little bit slow down for a while? Anyone have any questions?
आप लोग चैट में पूछ सकते हैं सर से क्वेश्चन या रेज हैंड कर सकते हैं.
यस सर.
जी सर.
मुझे ये बताइए कि इनमें से nobody will ask. I think I'll ask because I can see the names here, so I'll ask randomly.
जी सर.
So there's a yeah. So it's Luqman Rafiq. Luqman, can you hear me?
हाँ सर आपसे बात कर रहे हैं, आप मैसेज कर सकते हैं. सर आप पूछिए.
Luqman, do you have any question? Luqman, can you hear me? Yes, sir.
जी जी सर.
Can you please note it down the names and they are not responding to me? So you may ask. So Luqman, can you hear me?
Sir, can you just go with their roll numbers?
Yeah. So I'll call them. Just a minute. Hang on a sec.
सर आप अपनी पार्टिसिपेंट लिस्ट ओपन कीजिए. नीचे पार्टिसिपेंट्स है ना, कॉर्नर पे पार्टिसिपेंट लिस्ट आ रही है.
Participant list.
राइट साइड.
Yes, participant are 83.
तो बस आप यहाँ से कॉल आउट करें तो फिर मैं इजीली इनको म्यूट अनम्यूट करती जाऊंगी जो आप जिनको भी खाएंगे.
Okay. So Luqman was the roll number. Just a minute. Hang on a sec. I'll find out first. What was the roll number of Luqman was?
Sir, it's roll number 50.
Roll number 30. Luqman is roll number 30.
50.
Yes, it's roll number 50.
So you can ask with roll number. You can ask from roll number 53.
No, roll number 50 I want to ask first. Lukman, this is roll number 50.
सर आप पूछिए, लुकमान आप रिस्पॉन्ड करें, मैसेज करें.
Lukman, have you come across any kind of patient with GERD?
जी रिप्लाई कीजिए, इसी से अटेंडेंस चेक होगी.
Lukman is not answering. Anyways, we'll talk about, we'll discuss it with someone else. So, so roll number 63.
Sorry sir.
Roll number 63.
63. जी रोल नंबर 63 बोलिए.
Hello.
Hello. 63. Sorry, unmute.
63 left. Okay. Roll number 80. Suleiman Ayub.
जी सुलेमान.
Hello, Suleiman. Hello. You saw nobody's answering.
सर रोल नंबर नोट कर रही हूँ.
So, Yusra, मुझे ये बताओ, who's the topper of this class? Yusra,
जी सर.
मुझे बताओ topper कौन है class का?
You can ask about roll number 66.
56.
जी सर.
56.
हेलो.
Hello.
अस्सलाम वालेकुम सर.
वालेकुम सलाम. बेटा नाम क्या आपका?
सना.
Sana, have you come across any kind of patient with GERD?
Sir, not as yet. I haven't.
Okay. So anyone at your home?
No sir, alhamdulillah, nobody.
Okay. So can you tell me what you have understood so far?
Sir, I've understood the basic concept of GERD, which is basically a reflux of the gastric content from the stomach into your esophagus.
And yeah, go ahead.
It could, a lot of risk factors come into play, which could be excessive consumption of spices, alcohol, tobacco, delayed gastric emptying. But the main pathogenesis was obviously incomplete relaxation of lower esophageal sphincter.
Yeah, you're right. So basically what's happening here is definitely your lifestyle does matter. That is the most important step here. So again, as you mentioned regarding the smoking should be stopped. What happened is, as I mentioned before, the GERD is a clinical diagnosis, but if you have a red flag symptom, probably you'll be going for the procedure.
Yes, sir.
Do you have any questions, Sana?
None, sir, none as yet.
That's fine, thank you. I'll continue with my presentation. Thank you.
Thank you so much, sir.
So thank you, Sana. As Sana mentioned about, so what is the treatment? Goals of therapy. So alleviate or eliminate the patient's symptoms, decrease the frequency of recurrence and duration of gastroesophageal reflux, promote healing of the injured mucosa, prevent the development of complications. So this should be the goal, and you ask the patient about the symptoms, about the reflux, about the lifestyle and everything. So lifestyle modification again is very important. Avoid large meals, avoid acidic food, citrus tomatoes. Alcohol, caffeine can lead to again GERD. Chocolates, onion, garlic, peppermint. All these can lead to gastritis or GERD or leading to reflux esophagitis. Decrease fat intake. Avoid lying down with 3 to 4 hours after meal. Within 3 to 4 hours after meal. Elevate head of bed 4 to 8 inches. Avoid medicine that may potentiate GERD, like calcium channel blocker, NSAIDs, alpha agonist, theophylline nitrate, sedatives. So again, most of the patients usually usually admit under our care with NSAID-induced gastritis, only taking NSAIDs for pain and pain and pain, and then these. Avoid clothing that is tight around the waist. You need to lose weight, and because obese patients are more prone for GERD, and you need to stop smoking, as mentioned by one of your colleagues, antacids. Over-the-counter acid suppressants and antacids appropriate initial therapy. Antacids with kind of aluminium, kind of magnesium, with the name of Gaviscon, Neocaine, Digex, appropriate initial therapy. Approximate 1/3 of patients with heartburn-related symptoms use at least twice weekly. More effective than placebo in relieving GERD symptoms. H2 receptor blockers competitively block the histamine receptors in gastric parietal cells, thereby preventing acid secretions. More effective than antacids for relieving heartburn in patients, but nowadays H2 receptor antagonists are being banned because they say that it's carcinogenic. So ranitidine with the name of Zantac was most commonly used. And it may lead to definitely it was showing the results with healing faster healing of erosive esophagitis and can use regularly on demand. But again, this drug is banned these days, so probably nobody is using H2 receptor blockers. Yeah, somebody is using cimetidine. So H2 receptor blocker, famotidine, cimetidine, ranitidine. So ranitidine is banned. Proton pump inhibitor. Now, widely used, every patient, every doctor, every specialty using proton pump inhibitor with the name of omeprazole, esomeprazole, rabeprazole, pantoprazole, lansoprazole. So these are all other drugs that most of the people are using. Effective not only in patients with having erosive esophagitis or complications, but also with non-erosive GERD who have moderate to severe symptoms. Act by decreasing the basal and stimulated gastric acid secretion through inhibition of the final step of acid secretion by the parietal cell, proton pump, and better control of symptoms with API as compared to H2 receptor blockers, and a better remission and faster healing as compared to H2 receptor blockers. I just wanted to tell you, in your exam, the JSMU people have the key for H. pylori gastritis, because I'm not mentioning you about the H. pylori gastritis, and they have about the Barrett's esophagus. What is the definition of Barrett's esophagus? These are the agents which are available in the market: esomeprazole, omeprazole, lansoprazole, pantoprazole, and every medication has different dose strength, and the maximum dosage is also different. So, if the patient is not managed with oral therapy and patient having persistent, there's the endoscopic treatment, giving some injections to endoscopy. And if endoscopically, if it's not getting better, even hiatus hernia, all kind of stuff, you need a surgical procedures. That's what we call anti-reflux surgery, failed medical management, patient preference, ask patient always. GERD complication, medical complication attributable to a large hiatal hernia, and atypical symptoms with reflux documented around 24 hours pH. So this was all about GERD, about the management, about the complications, and about the treatment. Again, if the patient has the cause, that's what we call H. pylori, you need to eradicate the patients with H. pylori eradication therapy. But again, mind it, if you're working up the patient for H. pylori, the PPI should be stopped prior to H. pylori investigation, at least 72 hours prior. PPI should be stopped before the procedure. So Yes, I'm going to ask the question now.
Yes, sir.
Yes. Okay.
जी जी.
So let me see who is available. We'll find out him. So,
क्वेश्चंस आस्क कीजिए या रेज हैंड करेंगे और फिर आंसर
नहीं
करेंगे.
नहीं ये रेज हैंड नहीं करेंगे. I'll ask individually. Roll number 20.
जी रोल नंबर 20 से आप पूछिए.
Hello. 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 सर रोल नंबर 20 को अनम्यूट किया.
जी सर.
नाम क्या? Hello. 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 नहीं आ रहा रोल नंबर 20.
नहीं सर आंसर नहीं कर रहे अनम्यूट किया हुआ है.
Okay. Okay. Abdullah Muiz, roll number 1. Hello.
जी अब्दुल्ला.
Hello, Abdullah. Hello. Hello. नहीं देख रहे ना.
सर
रोल नंबर 38. अच्छा अब्दुल्ला ने मैसेज किया है. अब्दुल्ला कैन वी टॉक? अब्दुल्ला कैन वी टॉक? अब्दुल्ला हेलो. हेलो. इसका क्या हुआ?
रिस्पॉन्ड नहीं कर रहे अब्दुल्ला. रोल नंबर
अब्दुल्ला ने
38.
Yes, sir.
who is this?
Roll number 38.
Roll number 38. What's your name, beta?
Maheen Siddiqui.
Maheen, beta, can you read this question for me and for everyone here? What is the question written here on the screen?
A 35-year-old woman is evaluated for a 6-month history of an upset stomach that usually occur after meals. She also has heartburn symptom after meal at least 4 times per week. She reports no difficulty of pain with swallowing or no vomiting, weight loss, altered stool habit, or blood in the stool. There is no family history of malignancy. On physical examination, the vital signs are normal. Abdominal examination discloses a non-tender epigastrium and no masses or lymphadenopathy. CPC is normal.
Okay, so the next slide is the question. And so, read it for me again.
Which of the following is the most appropriate management? Proton pump inhibitor, sulfate, test for H. pylori, and treat if positive, or upper endoscopy?
So what do you think? What is the answer?
A. Proton pump inhibitor.
Okay, why not sulfate? Why not test for H. pylori?
Sir, because she has a history of heartburn and regurgitation of gas. Sorry, sir. Can you repeat the question number 1?
Oh, sorry, question. Yeah.
Because she has history of heartburn after meals, so might be we can give omeprazole or
Perfect. So very right. As mentioned before, that if a patient is having a clinical diagnosis, you may give a trial of API. And you're very right. And good. Thank you, Bache. Thank you very much.
thank you, thank you.
Sir, the next question is from anyone you select. किसी और को आप सिलेक्ट करें. 4 क्वेश्चंस हैं, 4 लोगों से पूछेंगे. माहिन से पूछ लिया, 3 और क्वेश्चन. किसी और को जिसको आपको लगता है कि वो रिस्पॉन्ड करेगा. इस आप लिख रही हैं ना जिनको हम पूछ रहे हैं और वो जवाब नहीं दे रहे. प्रॉब्ली वो ऑन करके सो रहे होंगे या ऑन करके बैठे होंगे कहीं. ऐसा
जी सर, रोल नंबर
नोट किया ना आपने?
जी सर, नोट कर लो.
बिल्कुल.
रोल नंबर 67.
रोल नंबर 67.
हेलो सर.
अस्सलाम वालेकुम बेटा, क्या नाम है आपका?
सर सना.
अच्छा सना. सना, can you read the question for me and for your colleagues?
Okay, sir. A 40-year-old woman is evaluated for a 1-year history of reflux. She has heartburn and regurgitation of gastric content several times a week. She was placed on lifestyle modification and on empiric trial of a once daily proton pump inhibitor 12 weeks ago with minimal relief of symptoms for the past 6 weeks. So he has taken proton pump inhibitor twice daily with minimum relief. She has had intermittent solid food dysphagia. She appeared to be adherent to her lifestyle and medical therapy. Physical examination disclosed normal vital signs and a BMI of 35.
So Sana, what do you think? What would be the question and what you're going to do with this patient? Are you going
Sir,
to treat or you're going to do something?
Sir, I will do lifestyle modification because BMI is 35 and she's already taking proton pump inhibitor, which is giving her minimal relief.
अच्छा सना बेटा देखो क्वेश्चन लाइन नंबर 4 में शी वाज ऑलरेडी प्लेस्ड ऑन लाइफस्टाइल मॉडिफिकेशन एंड ऑन एम्पिरिकल थेरेपी. तो लाइफस्टाइल मॉडिफिकेशन इनको पहले से बोलेगी और पीपीआई भी लेगी. सो व्हाट एल्स इट कुड बी? लेट्स सी व्हाट्स द क्वेश्चन इज. सो जस्ट अ मिनट. सो कैन यू रीड इट फॉर मी अगेन?
Which of the following is the most appropriate next step in management? Add an H2 blocker at night, employed esophageal pH study, endoscopy, fundophallication.
So add an H2 receptor blocker at night. So what do you think? What is the answer?
So add H2 blocker at night.
नहीं बेटा देखो, I just wanted to clarify कि H2 receptor blocker से superior है PPI. तो जब PPI पे respond नहीं करा तो H2 receptor blocker पे नहीं करेगा. So this option is out.
Okay.
दूसरा ambulatory esophageal pH study. Endoscopy fundoplication is अगर in a surgical procedure तो अभी surgical पहले medically हो जाए तो option should be B or C इन दोनों में से. अच्छा अगर आप देखें सवाल देखें इसमें रेड फ्लैग सिम्टम कोई है पेशेंट को?
Actually, sir, I was a bit late due to internet issue, so I just didn't go through the starting of the lecture.
Okay, so there's a red flag
bit...
symptom. There's a patient has having a dysphagia. So you are going for endoscopy. The answer is endoscopy, sir. Okay, thank you so much, sir.
So what's red reflex symptoms? Will you please repeat it?
I'll repeat you the red flag symptoms again. So you can see here, these are the red flag symptoms. Dysphagia, odynophagia, nausea, vomiting, melena, anemia, weight loss, anorexia, extended duration of symptoms, no response to PPI, family history of peptic ulcer disease. Caucasian male, 50 plus years and sex greater than 10 years, like concern for esophagus. So, got it? The red flag symptoms? Think endoscopy.
Yes, sir. Thank you so much. Sir.
You're welcome, Achia. Yusra, question number 3. Shariar. Shariar. Shariar,
G. Sarosh, roll number 86.
जी अस्सलाम वालेकुम मैम
अस्सलाम वालेकुम जी बेटा, क्या नाम है?
सरोज
सरोज। सरोज, क्वेश्चन को पढ़ें।
जी सर A 75-year-old man is evaluated in follow-up after recent surveillance endoscopy for Barrett esophagus. Biopsy from one of the salmon-colored columnar segments shows high-grade dysplasia. His GERD symptoms are well controlled with proton pump inhibitor therapy. His medical history is significant for New York Heart Association functional class 3 heart failure, ejection fraction of 30%. His medications are pantoprazole, furosemide, digoxin, metoprolol, enalapril, and spironolactone. On physical examination, he is afebrile, blood pressure is 100 by 50 millimeter of mercury, pulse rate is 62 per minute, and respiratory rate is 12 per minute. BMI is 35. There is no evidence of jugular venous distension. Cardiac rhythm is regular with a soft ST at the cardiac apex. The lungs are clear, no peripheral edema is present.
Okay, and what's the question here? So,
Which of the following is the most appropriate management? Endoscopic ablation, esophagectomy, fundoplication, repeat endoscopic surveillance in 3 years.
जवाब क्या है आपका?
Sir, periodic endoscopy surveillance of 3 years. Sir.
Great, wonderful. Right answer, because you can see the patient's symptoms are well controlled on API, and there was just on a biopsy they are showing us. So you may repeat endoscopy at some point in time with lifestyle modification and on API. The last question, question number 4, Yusra.
Roll number 22.
32.
Hello, roll number 22. Roll number 91.
Yusra, रोल नंबर 22 ने भी कहा कि मेरा माइक काम नहीं कर रहा है, शहरियार ने भी कहा मेरा माइक नहीं काम कर रहा।
Number 91. Roll number 11. Number 11.
रोल नंबर 52, मोहम्मद जकी शेख। जकी, सर कोई भी लड़का नहीं आया, सारी लड़कियां हैं।
Roll number 69. Roll number 14. Roll number 56.
Roll number 18. Roll number 18.
Sir,
Yeah. जी बेटा क्या नाम है आपका?
Sir Sania Jas,
What's your roll number?
69.
16. Okay, Sania beta, read the question.
Yes, sir. A 44-year-old woman is evaluated for a 1-year history of vague upper abdominal discomfort that occurs after eating. She is from a rural area in a developing country. She has not had nausea, vomiting, dysphagia, odynophagia, weight loss, or black or bloody stool. She is otherwise healthy. She has no personal history of peptic ulcer disease and no family history of gastrointestinal malignancy. Her only medication is a multivitamin. On physical examination, temperature of 36.8 degrees Celsius. Blood pressure is 127 by 82 mm mercury. Pulse rate is 72 beats per minute and respiratory rate is 16 per minute. BMI is 27. There's epigastric tenderness with moderate palpitation but no masses or lymphadenopathy. Complete blood count is normal.
Okay. So, question क्या है?
Which of the following is the most appropriate management? Helicobacter pylori stool antigen testing and initiate an H2 blocker, initiate empiric treatment for H. pylori infection, perform endoscopy.
So, what you are going for that?
So I think that we'll go for endoscopy.
Why is that? See, are there any red flag symptoms?
No.
No. So will you go for endoscopy straight away?
Yes.
Why? If the patient is not having any red flag symptoms?
Sir, first we'll start with proton pump inhibitors.
So see, now the option here is Helicobacter pylori stool antigen testing, initiate an H2 receptor blocker, initiate empirical treatment for H. pylori infection, perform endoscopy. So देखिए, अगर ये सवाल देखा जाए तो इसके हिसाब से अगर हमें ट्रायल एम्पेरिकली ट्रीटमेंट शुरू करना है तो इनिशिएट एन H2 रिसेप्टर ब्लॉकर. अगर उस पर नहीं आता देन यू गो फॉर इन्वेस्टिगेशन. तो द आंसर हियर इज बी. तो H2 रिसेप्टर ब्लॉकर हो या पीपीआई हो, लेकिन अगर इन दोनों ऑप्शन सेम हो तो पीपीआई शुड बी ऑन प्रायोरिटी. तो अगर कोई रेड फ्लैग सिम्टम्स नहीं है, यू आर नॉट गोइंग फॉर एंडोस्कोपी. पेशेंट को कोई सिम्टम्स सिर्फ एब्डोमिनल डिस्कम्फर्ट है तो यू जस्ट इनिशिएट एन H2 रिसेप्टर ब्लॉकर. अगर H2 रिसेप्टर ब्लॉकर और पीपीआई दोनों का ऑप्शन हो देन यू सेलेक्ट पीपीआई. ठीक है जी.
Okay, sir, I have a question.
Yeah.
Sir, when we will do this Helicobacter pylori stool antigen testing?
अच्छा देखिए, बहुत अच्छा सवाल है. जब अगर आपको स्ट्रॉन्ग सस्पेशन हो पेशेंट को कि पेशेंट को एब्डोमिनल पेन है, पेट्रोस्टल बर्निंग है, गैस्ट्राइटिस के सिम्टम्स ज़्यादा हैं. ठीक है, अभी तो हम GERD की बात करें, गैस्ट्राइटिस के सिम्टम्स ज़्यादा हैं. और अगर आपने H2 रिसेप्टर ब्लॉकर दिया और पीपीआई पे भी नहीं रिस्पॉन्ड करा तो देन यू नीड टू स्टॉप पीपीआई फॉर एटलीस्ट 72 आवर्स. पहले आपको पीपीआई को बंद करना पड़ेगा H. pylori, क्योंकि कुछ लोग देखेंगे, आप प्रिस्क्रिप्शन देखेंगे पीपीआई ले रहे हैं और H. pylori जो है वो टेस्ट करा रहे हैं, तो वो बेकार है, टेस्ट का कोई फायदा नहीं. ठीक है.
Okay, sir. Thank you.
Anyone have any question? सर से कोई सवाल?
जी. जी, रोल नंबर 19.
अस्सलाम वालेकुम सर.
क्या नाम है बेटा?
उमर अहमद सर.
उमर
सर, मुझे शुरू में ये सवाल पूछना था. जब हम लोग GERD की कॉम्प्लिकेशन की बात कर रहे थे, which was one of the Barrett's esophagus. Sir, I have had GERD myself since 2 months, and I have seen a lot of patients with GERD, and I've seen that Barrett's esophagus is a very rare thing that happens. So my question is, how chronic does GERD have to be for this Barrett's esophagus to develop?
अच्छा देखो, 2 महीने तो it's nothing. ठीक है. You need to modify lifestyle, and if you're smoking, you need to stop smoking. बट मैं आपको कहूँगा कि एग्जैक्ट टाइम फ्रेम इज नॉट मेंशन, एवरी पेशेंट इज डिफरेंट। कुछ लोग अगर आप देखा जाए आपकी हेल्थ कैसी है क्या है, तो बेहतर तरीका ये है कि अगर आपको सिम्टम्स हैं टेक पीपीआई। अगर आप पीपीआई लेंगे, अगर आपको लगता है, कुछ लोगों का ये भी है कि अगर आप देखें लिटरेचर में देखिए 6 weeks empirically PPI can prevent you from very bad complications like Barrett's esophagus। अच्छा, Barrett's esophagus से पहले भी आपको बार बार रिफ्लक्स एसोफेजाइटिस, अगर देखें उससे पहले आपको रेड फ्लैग सिम्टम्स आना शुरू होंगे। उससे पहले रेड फ्लैग, जब रेड फ्लैग सिम्टम्स आएंगे तो जब आप एंडोस्कोपी कराओगे तो उसमें आपको पता चलेगा। तो अभी आपको कोई रेड फ्लैग सिम्टम नहीं है, कुछ नहीं है, जस्ट टेक पीपीआई and just lifestyle modification। आजकल अफ्तार में रमजान में समोसे पकौड़े हो रहे होंगे, तो just try to avoid that for a time।
So there's no established time frame for
no established time frame, no। कुछ लोग कहते हैं कि 5 साल के बाद, कुछ लोग कहते हैं 10 साल के बाद, लेकिन Barrett's esophagus is like quite यानी ये समझिए कि ऐसी कॉम्प्लिकेशन है जो बहुत रेयर कॉम्प्लिकेशन है, मगर डिपेंडिंग ऑन, जी बिल्कुल, इट्स नॉट वेरी कॉमन।
Thank you, sir.
Thank you। Any more questions?
Verse 17. G roll number 17.
Hello.
Yes, Amika.
Walaikum assalam. Sir, I had a question. The question number 3 we discussed earlier.
Yeah. I'll bring it again. Yeah. Go ahead. पूछिए।
तो सर जब हमने इनकी बायोप्सी की and it shows high grade dysplasia, तो हम उसको ट्रीट नहीं करेंगे? Like it can go into complications.
अच्छा, अब देखिए, आप इसका सवाल जरा दोबारा देखें। 75 years old man is evaluated in follow-up after recent surveillance endoscopy for Barrett's esophagus. Biopsy from one of the salmon columnar segments shows high-grade dysplasia. His GERD symptoms are well controlled with PPI. His medical history से, so अगर आप देखें पेशेंट जितने भी Barrett's esophagus के हैं, पेशेंट को कोई और सिम्टम्स नहीं है, पेशेंट के सिम्टम्स सेटल्ड हैं, पेशेंट को पीपीआई कंट्रोल्ड, पीपीआई पे पेशेंट के सारे सिम्टम्स हैं। तो अगर पेशेंट को एसिम्टोमेटिक है, हाउ यू आर गोइंग टू ट्रीट द पेशेंट विद लाइक एसिम्टोमेटिक पेशेंट को कैसे ट्रीट करेंगे? और अगर आप इसके ऑप्शंस भी देखें तो इसका एंडोस्कोपिक एब्लेशन लिखा हुआ है, एसोफेजेक्टमी लिखा है, फंडोप्लाइकेशन लिखा है, रिपीट एंडोस्कोपी सर्वेलेंस एंड ट्रीट। पेशेंट के सिम्टम्स बेहतर हैं, you just wait and watch and see how things are getting, so you just need to wait for
Okay, sir. But there's a question कि can we keep the age जो उनके पेशेंट की है 75? तो हम उनको थोड़ा कह रहे हैं कि वो सिम्टोमेटिकली अगर मैनेज्ड हैं तो हम उनको ज्यादा कुछ ट्रीट नहीं कर रहे हैं, बट इफ द एज वुड हैव बीन यंग, मतलब यंग ग्रुप में अगर वो होते,
हाँ, अगर आप कहते हैं 40 years में, तो yes, the answer would be yes, we will treat the patient.
Okay, like the age factor comes in, right?
Yeah.
Okay, thank you.
Thank you. Any more questions?